There's two issues that I really haven't been satisfied with what I've heard from Medicare. Talk to us a minute about when Medicare requires MVPs, how do they define who can use a subgroup, or how will they? Do we know? And what do they do with providers who don't have an MVP that seems applicable to them?
Dr. Mingle, those are exactly the questions that come up when we talk about MVPs with clients. So to answer the first question of how does a practice know if they have to be a subgroup? How do they know if they're multi-specialty? The answer is we're not clear yet. We have obviously done a great deal of research. We've put in lots of tickets, and CMS has provided some information to help us understand how they're determining a multi-specialty practice, how they're trying to determine the difference between maybe what a physician has for a taxonomy as opposed to the type of care they're actually doing. It still isn't very well defined. What we are finding through tickets and support calls and questions into Medicare and their contractors is that it seems like there is an idea that a specialty or a multi-specialty practice would have different specialties clearly defined. So, for example, if you were a practice doing cancer care, maybe you have a hematology department or an imaging department and a palliative care department. What we're finding is lots of practices don't follow that clean and neat model when they're when they're multi-specialties. And even in the example of the cancer care, for example, you might have someone whose taxonomy is palliative care, but they're only working with cancer patients. And so advancing cancer care MVP would be very appropriate for the work they're doing, but may not match their taxonomy. CMS hasn't really clearly defined where the rules and lines are around that and how a practice or a vendor such as ourselves would be able to identify which MVPs are appropriate for which practices, providers, subgroups. So it's still very much being clarified and defined. What I do expect is with this 2026 timeframe kind of looming, either we will get a lot of clarification very soon in the next 9 months or so, or that timeframe might be kicked out a little bit as CMS kind of maybe gets some more resources available and has an opportunity to do some more education. The other question you brought up that I think is really interesting and important to address is what to do in the event that you are required to do an MVP, but no MVPs are available to you. Going back to this example of a cancer care center with a palliative care specialist, for example, there is no palliative care MVP at the moment. So in that instance, we're not really sure what CMS would expect from that palliative care provider. We're not exactly sure what they would have to do. Those are some of the ongoing kind of operation questions, I think, that hasn't fully been defined by CMS yet. They have a great idea with MVPs, and it makes a lot of sense. They want practices and providers to report on the type of care that they're doing so that patients can be healthier and costs can be lower. That absolutely makes sense to me. When we get into the nitty-gritty of how to do it, sometimes it takes a bit longer to sort out all the details and the rules and the pathways. And I think that's what we're seeing with MVPs. There's still some definitions and some resources that are needed from CMS. I expect we will get them. MVPs, I don't think, are going away. I don't think CMS is going to abandon the MVP idea. It's a great idea and works well in a lot of cases. But we definitely need some more clarification for practices to be able to be compliant with the regulations and still meet the goal of the program, which is reporting on patients and care that they themselves are giving. So it remains to be seen is the short answer.